Dear colleagues, in this presentation I would like to present a step-by-step approach for the clinical evaluation of elbow pathology. 8 steps are used: history and inspection, palpation, passive motion and active motion against resistance, a neurological examination, and a Lidocaine test. These 8 steps will allow to make a clinical diagnosis in 90% of the cases. Evaluation of elbow pain begins with a history including hand dominance, vocation and location of the pain. Medial elbow symptoms are often associated with golfer's elbow, MCL injury, flexor pronator injury, cubital tunnel syndrome, stress injury to the medial epicondyle or posteromedial impingement. Lateral elbow symptoms are often related to tennis elbow, radial head or capitellum injuries, plica injuries, posterolateral rotatory instability, or radial tunnel syndrome. Posterior elbow symptoms can result from triceps tendinitis or rupture and posterior impingement. Next, inspection. It's essential to examine the affected and the unaffected extremity for comparison. The normal carrying angle is approximately 11 to 14 degrees of valgus in adult men and 30 to 16 in adult women. Variation in carrying angle may be due to previous trauma, developmental abnormalities, injury, or adaptive changes. Ecchymosis and swelling may be localized to an area of acute injury. Difference seen in muscle mass may be due to injury or to hypertrophy in the dominant arm. The next step is the palpation of the elbow. The lateral epicondyle and the radial head can be palpated. Pain directed at the lateral epicondyle can be due to trauma or LCL injury. Tenderness to the lateral epicondylitis is theoretically just anteriorly and distal to the epicondyle at the origin of the extensor carpi brevis. There may be tenderness and associated clicking over the radial head with rotation seen in fractures, arthrosis, or asymptomatic posterolateral synovium placa. The medial epicondyle and the ulnar nerve can be palpated. Tenderness to the medial epicondylitis is theoretically just anterior and distal to the epicondyle at the origin of the flexor pronator group. The MCL is palpated with the elbow in 50 degrees to 70 degrees of flexion to move the overlying medial muscles anterior to the MCL. The ulnar nerve can be palpated in the cubital tunnel. Percussion along the nerve may elicit a tendinal sign. The distal biceps can be felt in the antecubital fossa in a flexed elbow. Direct palpation of the antecubital fossa for integrity of the distal biceps can be misleading, as the lacertus fibrosus may be still intact medially, or the brachialis can be mistaken for the biceps. Next, passive range of motion should be assessed. Normal range of motion is approximately 0 degrees of extension and 140 degrees of flexion. Normally there is a hard stop in extension when the olecranon hits the olecranon fossa, and a soft spot in flexion because flexion is limited due to contact between the forearm and the upper arm. Full extension is often the first motion lost after injury. Supination and pronation motion is approximately 80 degrees in both directions. To determine pathological differences, range of motion should be always compared with that on the contralateral side. Also, the stability of the elbow is tested. Valgus stability is provided by the osseous anatomy of the olecranon and the humerus, dynamic muscle forces, and the MCL complex. The interlocking bony anatomy of the olecranon with the olecranon fossa provides stability at less than 20 degrees of extension and greater than 120 degrees of flexion. Concerning the ligaments, the majority of stress is placed on the anterior bundle of the MCL complex. The classic valgus stress test is performed in abduction and external rotation of the humerus. Next, the humerus is stabilized in 30 degrees of flexion to unlock the bony restraint of the olecranon from the fossa and applying a valgus test. This test has a positive result if the medial joint space opens and the patient reports pain. Pseudovalgus instability, subtle posterolateral instability that can be present when the forearm is supinated, is eliminated as a confounding factor of possible medial laxity when the forearm is pronated. Two other tests for the valgus instability are the milking maneuver test and the moving valgus test. The milking maneuver test involves placing the affected elbow at 90 degrees of flexion with the shoulder at the side and 90 degrees of abduction. The examiner grabs the thumb and externally rotates the arm and supinates the forearm while applying valgus force on the elbow. thumb is pulled downward towards the floor as if milking the udder of a cow. The moving valgus stress is perhaps the most sensitive and specific for MCL injury. The shoulder is placed in abduction and external rotation, while the examiner holds the thumb with one hand and supports the elbow with the other. The elbow is gently flexed and extended while applying a valgus stress. A positive test will elicit pain at the arc of motion between 80 and 120 degrees. Varus stability of the elbow is provided primarily by the LCL complex, and damage to this complex causes a predictable pattern of injury. Varus instability is evaluated with full internal rotation of the shoulder and 30 degrees of elbow flexion. Chronic instability is rare, perhaps because the elbow is rarely stressed with a pure varus stress. Much more common are the posterolateral rotatory instabilities. Focused test for the posterolateral rotatory instability is often challenging to perform, and true instability may be difficult to elicit in the awake patient. The posterolateral rotatory apprehension test is also called the lateral pivot shift test. The patient lies supine with the arm overhead. A valgus stress and actual load are applied by the examiner with the forearm supinated, while the elbow is brought from extension to flexion. The radial head may subluxate when the elbow is gently extended at 30 to 40 degrees and may reduce with a clunk, often at greater than 40 degrees of flexion, or, when awake, the patient feels apprehensive. In the chair sign or stand-up test, the patient attempts to stand from a seated chair using his or her arms to push against the chair with the forearms maximally supinated. A positive test will reproduce the patient's symptoms. Next, active range of motion is assessed. As discussed during evaluation of the passive range of motion, the normal range of motion is approximately 0 degrees of extension and 140 degrees of flexion. Supination and pronation motion is approximately 80 degrees in both directions. Next, several active tests against resistance can be performed to evaluate the strength and the pain sensation of the different muscles. The brachialis is tested with resisted flexion with the forearm in pronation. For evaluation of the biceps, a resisted flexion of the elbow is performed with the hand in supination. The triceps is evaluated with resisted extension of the elbow. Next, the biceps. The hook test involves hooking the examiner index finger underneath the tendon from the lateral side with the elbow in 90 degrees of flexion and full supination. Sensitivity and specificity are reported to be 100% for a full tear. The bicep squeeze test is the analog of the Thompson test for Achilles tendon rupture. Sensitivity and specificity are reported to be high, and patients who undergo successful repair exhibit return of a positive squeeze test. The primary structure involving in all cases in the tennis elbow is the extensor carpi radialis brevis tendon. Pain can be evocative by dorsiflexion of the wrist against resistance. This is more painful in extension of the elbow than in flexion. Also, lifting a chair with pronated hands can induce pain at lateral epicondyle. The primary structures involving in golfer's elbow are in the majority of cases the flexor carpi radialis and the pronator teres origin. An additional complicating factor associated with medial elbow tendinosis is cubital tunnel syndrome. Pain can be evocative by palmar flexion of the wrist against resistance. As in tennis elbow, this is also more painful in extension of the elbow than in flexion. Also, lifting a chair with supinated hands can induce pain at the medial epicondyle. At last, the neurological examination. First, the sensation on the dorsal and volar side of the lower arm is checked. Loss of sensation in the region of the radialis medialis ulnaris of musculocutaneus is evaluated. Motor activity can be checked quickly with 5 movements. Extension of the wrist by the nervus radialis, extension of the thumb by the nervus posterointraosseus, abduction of the fingers by the nervus ulnaris, the O sign by the nervus anterointraosseus, and opponents of the pollicis by the nervus medianus. Irritation of the ulnar nerve can be tested by a positive Tinel sign or by a reproduction of the symptom after hyperflexion of the elbow during 1 minute. Subluxation of the ulnar nerve can be tested when putting the thumb on the medial epicondyle in a hyperflexed elbow. When extending the elbow, redislocation of the ulnar nerve can be felt. At last, infiltration of the elbow joint can be interesting for diagnostic reasons. Three landmarks need to be filled: the radial head, the lateral epicondyle, and the olecranon tip. In the middle of the triangle formed by these three landmarks, there is a soft spot. This is the location for the infiltration. The needle needs to be angled to the medial epicondyle. With this step-by-step approach, most of the elbow pathologies can be diagnosed. Good luck.